I spent a lot of time on this show talking to innovators from all around the country, or even the world. But today, I want to focus on some of the amazing innovation happening at the Children's Hospital where I work, Children's Hospital Los Angeles.
Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before we get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started.
15 seconds after you meet Dr. Jeffrey Gold, you realize that he's an innovator. When you talk to him, you can tell that he spent time in Boston and the Bay Area, and now, of course, he's in Los Angeles. He's a licensed psychologist who helps children with pain management. A few years ago, he was working with Disney Junior and Doc McStuffins to help kids prepare for their surgery. If you talk to anyone in the mixed reality space, they'll tell you that he's one of the OGs of using VR in pediatrics. I hope you'll enjoy my conversation with Dr. Jeffrey Gold. You have been a pioneer in virtual reality and its application in pediatric health for so many years. You got started in this almost 15 years ago. Why is it so powerful? Why do you think it can make a huge impact in kids?
The secret sauce, right, to virtual reality technology in the head-mounted displays is really about immersion. A lot of people talk about VR as being a distraction and that you're just basically blocking, occluding the visual of the patient, say, seeing a needle being inserted for blood draw or for IV placement or some other painful procedure. But it's much more than just distraction alone. We recognize that it's around cognitive load. And when you can immerse somebody in the presence of a gaming experience, a journey, an adventure, even just some passive content where they're just watching something that they really enjoy, that level of immersion can really transport them to some other place. So simplified, mostly people just talk about it as, oh, it's distraction. But we know neurocognitively and we know neurologically, it's much more complicated than that. And kids really take to it, fish like water, right? Kids love technology. They love gaming. They love trying new things. They're not afraid to push buttons and go into certain doors and pathways and et cetera. So it's a natural fit that a child or an adolescent would really take to this quickly and enjoy it. And it really enables them to be somewhere else, having a good time. And even from a neurochemical standpoint, if they're having a good time and they're experiencing joy, they're probably also spiking some kind of endorphin, right? They're kind of having a chemical response where they're kind of laughing or giggling or having fun or feeling competitive. They want to win or score more points. And when that happens, the procedure is happening in parallel and they can really care less for the most part. And they're really, sometimes we'll have kids say to us things like, when are you going to start the procedure? And the procedure was done 2 minutes ago. So that's really powerful. And from the mouths of young patients, like these are the things that they say to us, is that it's very transformative, it's immersive, it's exciting, it's interesting, and it really does manage their anxiety, like their what we call pre-procedural anxiety. It manages the pain associated with that, with the medical procedure. So we really see that it has a very robust and profound impact on pain management and anxiety management around necessary medical procedures.
Has there been anything that surprised you in terms of findings from decades worth of research in VR?
I think what surprised me the most is that as the gaming companies got more engaged with us, because like when I started in 2002, I had one headset that was $50,000 that I bought from a startup company in Irvine. And I had one virtual environment that was made by an artist. She made one artist installation that was recoded into VR. And that was all we had. One headset, one game, and that was it. Now you have lots of headsets that are $200-$300 a pop, and you have thousands of virtual environments. virtual experiences that anybody can access on YouTube. So what I found is that as the field has grown, either because people believe in it or they think it's cool technologically, the advancements have really enabled us to move into new areas, right? We've moved into new areas around what we call sedation sparing activities, which is cool. Like kids who come in for procedures like transnasal endoscopies to monitor a disease of the GI tract would normally have to be sedated every time they come in. But now our doctor in GI has eradicated the sedation and only does her T&Es, transnasal endoscopies, with VR. So now a kid who used to get 10, say, transnasal endoscopies a year with sedation and all those negative side effects now can come in and do it with VR and have no side effects. So there's no NPO at midnight doesn't exist anymore. They can eat and drink. They come in less than 5 minutes later, they're bouncing out of the clinic. They're fine. They're done. They're back to school. The parents are back to work. The old way was nothing per oral at midnight, no water, no food. When they come in, they're hungry and cranky. They get sedated. They feel nauseous, dizzy, lightheaded. There's a PACU, a recovery period. All that's eliminated now. They might even vomit. They might miss school. Their parents miss work. All that's been eradicated now with VR as her clinical service line now. Every kid who gets a T&E uses VR. And so that is a huge advent in the use of VR for what we call sedation sparing. Now, mind you, those little side effects like nausea, vomiting, dizziness, yeah, those seem like nothing, but the exposure to the anesthesia 10 times, right, in a young developing brain, right? The literature really demonstrates that there are neurocognitive impacts from the neurotoxicities of anesthesia over time. So kids with chronic illness, which is like 70% of our market share here, they're getting exposed to anesthesia all the time, right? And we recognize that that may not be a great outcome for them long-term cognitively. Now, that's not final data. There's preliminary data out there about that. And so being able to have options like this for non-sedated T&Es or sedation sparing is just great. That's like a landmark finding. And everyone's happier. I always do triangle data analysis where I collect data from the healthcare provider, from the parent, caregiver, and the kid themselves to get everyone's perspective. It's like that 360 point of view. And all folks are super happy with these outcomes. And they choose VR now.
Is there a technology that's out there, something new that you're excited to learn more about, to research, to do a study on?
First thing is that the head mounts have gotten smaller and smaller. And right now, obviously, they're like in the size of my glasses and your glasses. They're like Ray-Bans, right? They're basically Ray-Bans now that can deliver a 360 experience in what looks like just a pair of eyeglasses. I think that's really cool because some kids have issues with the head mounted display, whether they have some sensitivities or something of they don't like anything on their hair or whatever. So I think that I'm excited to trial that in the future soon. I'm agnostic, so there's not a particular company per se. I just said Ray-Ban because that's a style. But you saw Meta and Ray-Ban. Meta's also partnered with Oakley, and so they have these larger glasses that can film things, but also can deliver content to you. So I'm excited about that. I think the smaller we go, the better. And you and I had this experience together. We went to Google, talked with them about Google Glass. They just hit the market decades too early, honestly. And now we're returning to that paradigm, I'd say. I don't know, not Google Glass per se, because that was a different model, but we're coming down to that size again, which I think is really exciting. So that's something I'm excited about. The other thing that I'd like to be able to solve, I don't have the skill set to do it, but is to really integrate biosensors into the VR technologies such that we get real-time metrics, right, for heart rate, respiration, EEG, galvanic skin response, HRV, heart rate variability, like something that could be integrated into the headset such that while we're doing our trials and also while we're impacting people's physiological output, that physiological output could also be driving some of the content or the activity that it's like a biofeedback, neurofeedback VR experience that would give us objective data about what's happening to them, around pain, anxiety, laughter, fear, whatever it is, and also use it to control the environment that they're viewing. I think that would be a real win-win for a lot of people, and it'd bring a whole new level of data to the table that hasn't yet been delivered in a integrative holistic manner. Because right now, most of our VR studies are by observation. We might record something or take notes in the field and then have them report to us their experiences. It'd be lovely to get some of that real time physiological data simultaneous to the intervention. This is me just talking about procedural pain management for painful procedures, right? But for folks who are using VR for, say, like mental health, for relaxation, for mindfulness, for stress management, for maybe managing depression, anxiety, PTSD, etc., a lot of these measurements could be really great for helping a person plug more into their experience so that they could actually what we call emotionally regulate. That's a big thing these days, ER, learning how to emotionally regulate yourself can help you talk yourself down from that cortisol explosion, that sort of a stress response, right? I would love to see that happen. I've talked about it at conferences a lot. I've heard companies talking about wanting to build it. I've seen a couple of examples that weren't so great, but I think it's not impossible. I think that would be very exciting. Then the last thing I'd say is that a lot of people, they are moving to 2D. They're deciding to jettison the headsets completely and move everything to laptop, tablet, or smartphone. And I can see the advantage of that. But until we test it to know whether it's immersive enough, do kids feel immersed and involved and engaged the same way that they do in head mounted displays or glasses is to be determined. But a lot of companies are moving that way because of access. Like, and I get that. Not everybody has access to a Meta or a Pico or something else, but most 99% of people have access to some tablet or some kind of a smartphone.
Dr. Gold, thank you for joining us and
My
all
pleasure.
the great work you're doing.
Thank you, Omkar. It's always a pleasure to see you.
Did you know that unlike CT scans or X rays, MRIs don't use radiation? And that's especially important for children who typically live long enough to potentially see the impact of radiation exposure. Dr. John Wood, he's the director of cardiovascular MRI at CHLA. He's doing some incredible work to enable clinicians to use MRI for more imaging use cases to enable better clinical decision making without the potential concerns of radiation. Dr. Wood, most MRIs today focus on the brain, the spine, and joints. Why have stronger magnets traditionally been the gold standard? And what challenges do they face when imaging areas like the chest, the lungs, the abdomen?
There are definitely advantages to going to stronger magnets. The signal that comes from these organs is stronger with the higher field strength. And in addition, the contrast between certain tissues, for example, the white matter and gray matter of the brain, actually increases with the field strength. So that's all good. And that has been driving over 90% of the MRI market. But where those stronger magnets really fall down is in any part of the body where there's air or an air tissue interface. And so the chest, the abdomen, all of your intestines are full of air, all of the gastrointestinal tract. In fact, even your face has air in your sinuses and your windpipe. And so all of these areas are very challenging by the higher field strength MRIs.
Now, you've told me that CHLA is one of the first children's hospitals, I think, in the world to install the Siemens Freemax. This is a low field MRI system. And so it's able to do some of the same work with a lower field MRI. So how is that transformative compared to the conventional 1.5 or 3 Tesla scanners?
Certainly, it is able to take really nice pictures of these areas of the body not served by the high field MRIs. So that's one key component. For example, lung imaging is exceptional on the 0.55 Tesla magnet. You don't hear of people going for lung MRI. It just doesn't happen. It's all done by computed tomography, which is wonderful in adults. But in kids, the radiation risk is unacceptable. So there's a real window of opportunity for the Freemax in that arena. But there's a second key advantage of the low field MRI is that we can actually take images faster. For example, a typical image of a beating heart is not like an ordinary movie. It's not in real time. It takes about 13 to 15 seconds to collect that image. And then we use an electrical signal of the heart to try and sort out all of the different pieces of that heart moving. But if the child moves in that 13 seconds, the image is a mess. So the Freemax is able to take real time video camera type images of the heart, which we believe will be transformative in pediatrics.
So even if the child moves, it wouldn't ruin the image? Is that what you're saying?
We all know that if you take a picture of someone doing jumping jacks, it's not going to come out very good. And the same thing with standard MRI procedures of the heart. If the kid is wiggling around, we can't make any sense of the images. But when you're taking pictures like a movie, even if the child wiggles, you still have pictures of the heart. Now, they have to be sorted and put back together because the child's moving. But with modern AI tools, this sort of volume reconstruction is becoming much, much simpler and faster. So we're very excited about exploring this in the pediatric population.
That could be a sizable game changer because you've got that challenge in imaging with children moving. And if you're able to, using AI and this type of radiologic approach, you can theoretically solve for that issue.
Yeah, and I just recently did a review of all the MRIs and CTs of the heart that we've done in the past 5 years. And what I found is that for children under 7 years of age, many of them are being sent to the cardiac CT scanner instead of the MRI scanner because it can collect images in a snapshot and to therefore avoid the need for general anesthesia. Whereas for us, currently, we've had to put in MRI, we've had to put those kids under general anesthesia. But with these newer techniques, our goal is to make it so that you don't need any radiation and we can collect these beautiful images of the beating heart without the need for general anesthesia. And I agree. I think that would be truly a game changer.
We're sending kids to CT where there is that radiation,
Yeah,
but it's largely because we don't want to put them under anesthesia. But and the reason we're doing anesthesia for MRI is because they're moving, and
exactly.
if you don't have anesthesia, so if you're able to do this with MRI, you're reducing the radiation, you're reducing the need for anesthesia, you're still able to get great quality pictures. So that seems like a win-win for the kids.
And we have a real proof and concept study going on right now where we're actually using this technology in the low field magnet to take pictures of children in utero, fetuses, and fetal cardiac MRI, which is an amazingly challenging problem because there's no way to get any electrocardiogram from a fetus. It's inside mom's tummy. So there are no synchronization signals and the baby moves about every 15 seconds or so, typically, if they're awake, as any mother will tell you. And so you've got this tiny little heart that's moving all over mom's abdomen and no way of synchronizing the signal. And yet we're able to get diagnostic quality cardiac images from these babies. And so we've still got a lot to do to make this so that it's fast enough to integrate it to the clinical workflow. This is still very much a work in progress. But if we can take pictures of the fetal heart, we can take pictures of a 3-year-old. That's a lot easier.
What were you doing before? What's the standard prior to this type of technology for fetal images?
Fetal ultrasound is still very good. And that's how we do most of our fetal cardiac work. However, there are times when the baby is in a bad position and ultrasound can't reach the heart. Mother's habitus may be large. Sometimes, if they've had prior surgeries, for example, the abdomen doesn't transmit sound or the placental location may be bad. There's a whole bunch of reasons why the fetal cardiologist just throws up his hand and says, I can't see. And that's where fetal cardiac MR will really be beneficial.
And you talked about air, and you talked about how in our GI tract and our pulmonary tracts, that's one of the challenges of the traditional approach. Do you think that this type of Freemax solution that you have could open the door for diagnosing and monitoring conditions in the GI and pulmonary space as well?
Oh, absolutely. The lung is an absolute dunk shot right now. We are getting gorgeous images that are just slightly lower resolution than CT, but they're suited for serial monitoring. So we have lots of children with chronic lung disease of various pathologies, either because of prematurity or genetic diseases. And we don't use CT in them because the radiation burden is unacceptable. But we need better mechanisms of monitoring our response to therapies. And lung MRI at low field is absolutely going to become that tool. I'm 100% convinced of it. And we have 3 or 4 investigators at this institution who are exploring these avenues. I also think, though, that it has tremendous application in the GI tract because of this ability to image in real time. We can watch, for example, people swallowing water and see if it's going down the right pipes and how well it enters into the stomach, how well it empties from the stomach. So I think a number of tests that we are doing under X-ray fluoroscopy, we could replace with what I would call MRI fluoroscopy. The key difference is MRI has no radiation. It doesn't damage DNA. So you can take as many pictures as you want at zero risk to the child.
So guiding catheters, and there's a lot of uses for fluoroscopy right now. So you could theoretically replace even those or shift some of those towards this MRI fluoroscopy to a certain degree.
Well, yeah, and certainly in cardiology, we drive catheters all over the vascular system. We go up the arteries and veins of the leg and of the neck and drive them into the heart, and we measure pressures and we blow up balloons. And all of that's done under X-ray. And it's not a small amount of radiation that is delivered to the child when we do that. And we're certainly very enthusiastic about the possibility of doing this with the FreeMax. And we have a strong partnership with both Siemens and USC to develop these techniques for what's known as interventional cardiology.
Has there been data showing the impact of radiation in kids to adults and what that could do? Has anybody studied the long-term impact of perhaps a large amount of radiation in children based on imaging?
These studies are very hard to do because the radiation risk takes many decades to show up. The reason why you and I can undergo CT at will is we're not going to live long enough for the cancers to show up. But that's not true in a 10-year-old or anyone in the pediatric population. I have seen studies which suggest that a simple abdominal CT scan causes a risk of leukemia of about 1 in 1,000. Some of these fluoroscopic procedures are a lot more radiation than a single abdominal CT scan. And there are people who will argue with that number. They are hard numbers to get. But the bottom line is if you don't need to undergo radiation, you shouldn't do it.
No, especially for children, because to your point, the length of life after that.
We do know that our kids with congenital heart disease that make it into their 40s and 50s have a very high incidence of secondary malignancy. We know that already. So
Now you're working with the USC Viterbi School on some collaborative work. Can you share a little bit about the partnership with the engineering school at USC and how that's helping
sure.
you advance some innovative things?
Yeah, and I really have to give a very strong shout out to Dr. Krishna Nayak in the Viterbi School. This is the whole reason we have a free max at Children's is because he had the vision about 8 years ago that this would transform pediatric cardiac imaging. Indeed, cardiac imaging in general. He works mostly in adults. And we partnered to write a grant, an instrument grant, to get essentially a low field magnet for him at Viterbi. And he has been developing all kinds of novel real time cardiac imaging methods at his center. And Children's, as a partnership, were designated as a center of excellence by Siemens for development of these new low field techniques. So they're the bench, we're the bedside, and we are really moving these novel techniques into the clinical arena.
How long do you think it'll be before we get to this vision that you have around MRI being an option for fluoroscopy, for imaging of the GI and lung tracts? Are we years away? Are we decades away? How far are we from it becoming more of a standard?
That's a very good question. We're actually, the lung imaging, we are doing some validation studies currently with children from the neonatal intensive care units. The goal is to roll that out clinically in the next 6 months. So I would say lung imaging is such a low hanging fruit that we're going to see clinical applications 2026 anyway, for sure. And we are still working to get the instrumentation all tuned to do the beginning interventional work where we're driving catheters under MRI guidance. I think we'll be starting research imaging in 2026 with clinical imaging in 2027. So that's a short horizon as well. The GI imaging, I think we've got pilot studies planned in the new year. It'll have to depend on how those look, whether the techniques are as promising as the initial studies look. And I would say all of the things we've talked about are within the 5-year timescale.
So, less radiation, more opportunities to use imaging to get more information to clinicians, and doing so in a way that probably is better for patient clinically, but also the patient experience. It seems like a triple win here.
Yeah, I would absolutely agree. The low field magnet, into addition to doing all these wonderful things, is 10 centimeters larger bore than the largest magnet out there. So it's more comfortable. The low field is quieter, it makes much fewer knocking sounds. So you still wear ear protection, but it's not deafening the way the higher field strength magnets are. And so I think from a patient experience, it I've been impressed. Patients have told me how much nicer it is compared to the standard way of doing things.
Dr. Wood, thank you for joining our show.
Thank you very much.
Recently, I was invited to visit Dr. Amatruda's lab. My colleagues told me that I was in for a treat. The hype was tremendous. So I walk into the research tower, and after some security checks, I put on some protective gear and walked past some heavy doors into what I felt like was a movie. I could hear the distinct sound of fish tank bubbles, and as I looked around the corner, I saw what felt like endless rows of fish tanks, all looking nearly identical. This was Dr. Amatruda's famed zebrafish lab at CHLA. Dr. Amatruda is the chief of the Division of Pediatric Hematology and Oncology. He's also the director of the Cancer and Blood Disease Institute, CHLA. And through the support of the Alfred E. Mann Family Foundation, he has this impressive zebrafish lab focused on translational research that's helping make so much progress in learning about pediatric cancer. Thank you for joining us, Dr. Amatruda.
Wonderful to be here. Thank you.
I had the pleasure recently to visit your zebrafish lab, and it blew my mind. It was an incredible display of research coming to life with rows and rows of little fish. But before we get into that, tell us a little bit about how you got into zebrafish and why are zebrafish so important for research?
So I'm an oncologist by training and background. And throughout my career, I've had the really wonderful privilege of mixing scientific basic research with clinical work. And I find that the two really go together very well, meaning everything that I do is really driven by the patients I see and their needs and our continual need to improve outcomes in childhood cancer. And I think the way we do that is through research. So I have also the great privilege of having run a research lab and continue to do so. And that's where we can take the lessons we learn from our patients, whether it's insights about the mechanisms of disease that we can then delve into the lab, or even when it comes to defining unanswered questions or problems that patients and the clinicians caring for them are facing. Is there something we can do on the research side to drive progress in the field? For me, that's incredibly motivating. So this is where we get to the fish part. I did not set out to be a fish farmer in my career, but back when I was doing my training, my MD PhD degree, the work I did involved genetics, meaning using understandings of genes, the instruction sets that are in cells and tell a cell what to do. How do genes interact? How does genetics really underlie health and disease? And the system we worked with was Baker's yeast, the same organisms that make bread and beer. They're very powerful for studying in the lab because their genetics are simple and well understood. During that time, I did research using Baker's yeast to understand how cells move and use their internal structures and filaments to move things around.
Is there similarity between the genetic composition of Baker's yeast and humans?
Oh, yes, that's a great question. So it turns out some of the very basic things like how do cells divide? How do the mitochondria and the other constituents inside a cell, how does the DNA get segregated? All of that is actually conserved from yeast to humans. The specific protein we were working on is called actin, which is one of the major components of muscle. It's one of the things that allows us to move our muscles. So the actin from a yeast cell and a human are about 98% identical, which is one of the reasons we use that system because it was relevant to human disease. So
I didn't
fast
realize that.
forward
That's
a few
interesting.
years, I've done my medical training and specialized in oncology, very captivated by the wonderful patients I'd met and the challenge of trying to improve outcomes. And I knew I wanted to incorporate research into that. And I was taken with the idea of using genetics and genetic tools to try to rapidly make progress in understanding human diseases, in this case, pediatric cancer, and trying to do something to improve those outcomes. But yeast don't get cancer. That's at the end of the day. They don't develop tumors that interact with the immune system and that grow blood vessels and that spread around the body. But right around that time, it turned out there was a new experimental tool, a new research system coming into the fore, and that was the zebrafish. So zebrafish are small aquarium fish. You can actually see them at most pet stores. A lot of people keep them in their home aquariums because they're very hardy and easy to grow. And about 30 years ago, zebrafish were adopted by the international community as a research tool for understanding development and disease. And the reason is they're a very powerful model. They're very easy to work with, but also they're very similar to humans. Did you know that in a fish, the spleen and the heart are on the left side of the body and the liver is on the right side of the body, exactly the same as
Just
in
like
a
humans.
in fact, about 85% of genes that cause disease in humans have an exact identical counterpart in the zebrafish. So they're relevant, which was very important to us. And also they're quite powerful. Now, when you were in the fish lab, you could see that we have rows and rows of tanks. So we can grow a lot of fish in a small space. And that's important because we have huge ambitions. We want to study all the genes that could contribute to disease. We want to take a very comprehensive look.
And if I remember, they're somewhat translucent, right? You can see what's going on in the fish, whereas with some other fish, that may not be possible.
This is a key feature. Certainly at the very early stages of life, the fish are transparent. In fact, a zebrafish, the way they reproduce, the mother lays the egg and the male fertilizes them. And so those developing fish grow, they can grow in a petri dish, a little plastic dish in the laboratory, and we can watch them go from one cell to two cells to four cells, et cetera, et cetera, et cetera. And within 24 hours, there's a little fish under the microscope. Now, it doesn't look quite like Nemo or Dory quite yet. They don't have all their fins and flippers yet, but they have a fully formed eye, a developing brain. The heart is beating, the blood cells are circulating. And if you look at those blood cells under the microscope, they look just like human blood cells in almost every respect. So a lot of people who study zebrafish are very interested in those early developmental processes. How does the eye form? How does the jaw form or the heart? In fact, there are wonderful investigators, even here at CHLA. Dr. Ellen Lien, my colleague, studies heart formation. And this has great implications for congenital heart disease. She also studies how the heart regenerates, another amazing property of fish. In my case, I was very interested because I had the sense that the fish would be a very powerful way to study the intersection of genes and disease. So we now know, based on the work of the past 20, 30 years, that changes in the DNA, so mutations or changes in the instruction code that tell a cell what to do, are really at the root of basically all cancers. If we can now identify those mutations that occur in the tumors that occur in our patients and recreate them in a zebrafish, in almost every case, we can recreate that same tumor type. And now then we have an animal model in which the true development and sort of physiology of the cancer can be studied. Everything from how it goes from a single transformed, or everything that goes from how we can study the process starting at a single cell that has acquired a cancer mutation that becomes 2 cells and eventually 4, and it grows into a tumor and starts to interact with the immune system, starts to grow blood vessels to feed its own growth.
And why is this specifically important for pediatric oncology?
It's a great question. So it's turned out that the fish has turned out to be a fantastic model for studying pediatric cancers for 2 reasons. And one is exactly that aspect of development. So we now know that many pediatric cancers can be thought of almost as errors in development of a tissue. So contrast this to cancers that are more common in adults, like lung cancer, colon cancer, breast cancer, where often it's wear and tear on the DNA from exposure to toxic chemicals or aging. In a child, something very different is going on. Instead, we find that it's the same processes that are supposed to be there to allow proper formation of a liver, a kidney, the brain, whatever organ it is. A critical mutation that interrupts that process really blocks that normal development. And that seems to be at the root of many childhood cancers. And we can study that process in the zebrafish because it's very accessible to us. And there's a lot of tools and expertise for studying developmental biology. That's one reason. The other reason is that many people don't know this. Cancers in children tend to be genetically simpler than cancers in adults. A typical breast cancer, lung cancer, melanoma in an adult, the cell might have 200 or 300 different mutations or changes in the DNA. At the other end of the spectrum, in pediatric or childhood cancers, it's sometimes there's only one genetic mutation identified in the tumor. So to actually model that in a system, to recreate that in an animal model like the zebrafish, is technically much simpler. And I think that's the other reason.
Very interesting. You're able to recreate these mutations in these zebrafish. What does that allow you to study?
We have 2 main goals for doing that. When we build these tumor models, we create a zebrafish model of a specific pediatric cancer. And the first goal is to really understand the biology better. Despite all the progress we've made, we now cure about 75% of children in this country who are diagnosed with cancer can expect to be cured. And that's something to celebrate. But it's really an incomplete number because, first off, it's not 100%. And at that level, it's totally unacceptable. But also, we know that the treatments we use, even though they're effective, can have really tough side effects,
Right.
both in the short term and in the long term. So that's something we worry about quite a lot. So to me, that means we just don't have enough understanding to develop treatments that are more specific and effective and have fewer side effects. We need to have ways to really deeply study the biology of the tumors. And that's what the zebrafish model allows us to do. But the second part of it is actually very practical. Childhood cancers tend to be rare, which I'm very happy about, but it makes it difficult to do a clinical trial because it can take years and the cooperation of multiple institutions to even identify enough patients to try a new trial. With the fish, we can make hundreds and hundreds of animals that can enter a clinical trial. So another reason we like the zebrafish system is it's very good for testing new therapies. In fact, we can very often just put drugs into the water, allow the fish to swim around in the water. They take the drug in through their gills, through swallowing it. There's other ways, of course, to administer medicines to zebrafish. But the point being that we can generate experimental test subjects and rapidly test new therapies to really find the most promising new candidates to move forward towards the clinic. So it can be a tremendous time saver.
So, on that note, how many zebrafish do we have here?
Right now, we have about 70, 80,000. But I want to say that one of the really wonderful things for me in coming to Children's Hospital Los Angeles was the tremendous investment made by the institution and the Department of Pediatrics to enable me to bring my research program here. And very early on, we jointly hit on the big vision of let's build a big facility, a beautiful, large, state-of-the-art facility that could hold 200 or 250,000 fish. And so with that perspective being that we'd like to be able to tackle other pediatric diseases. Zebrafish are used not only for studying cancer research and for other things, as I mentioned, congenital heart defects, craniofacial defects, but also epilepsy, diabetes, autism, limb regeneration, infectious disease, the list goes on and on and on. And so now that CHLA has distinguished itself by building this state-of-the-art facility, we're hoping to recruit even other research groups in to build the community and take advantage of this amazing resource.
It's funny, there's so much talk these days with artificial intelligence about creating something called a digital twin, which would be essentially a digital replica of a person's genetic and other biometric features. Seems like this is the precursor to that. From a zebrafish standpoint, you can replicate a lot of what happens to a child, whether it's oncology or other diseases. It may not be the exact copy, but you're able to study what could happen to that child and how therapies could treat and remedy some of the issues the child is having.
Yeah, it's an excellent point. We need to embrace and utilize AI with the proper amount of sort of skepticism and checks built in. But I see these as very complementary efforts, meaning the thing about working with a living organism is it's humbling. It teaches you constantly what we don't know, but it also gives us the tools to try to overcome those knowledge gaps. And if we're building digital avatars or digital twins, we can build also experimental model system. And those two types of approaches can inform each other. And really what I'm interested in at the end of the day is how do we make rapid progress? Because these children can't wait.
I wasn't aware of the 75% number. It is both reassuring, but also to your point, that's not 100%. And I'm hopeful that through your research and through your lab and through the advances that zebrafish can offer us, that we can get that number higher and hopefully as close to 100% as possible someday.
That's certainly our goal.
Thank you, Dr. Amatruda, for your time and for all the work that you do.
Thank you.
All right, thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast.